We randomized patients after 4 cycles of chemotherapy, and they were basically partial responders or stable disease, and they were randomized to observation, which was the standard of care, versus consolidation chemoradiotherapy. And the consolidation chemoradiotherapy was 45 gray along with concurrent capecitabine in phase 1, which was followed by a boost of 9 gray to the gross target volume. And the patient numbers were total 135 after screening 200 patients, and there were 67 in observation arm and 68 in the radiotherapy arm. And after randomization, though there were some dropouts, but the key finding, our main aim was to see an improvement in overall survival. And after randomization, we found that the overall survival in the observation arm was 4 months as compared to 10 months in the chemo-radiation arm, and the p-value was significant, and this amount of difference has not been seen in the hepatobiliary, in the biliary cancers, not even with immunotherapy. And so therefore this is practice changing, and it should be adopted at least in the gallbladder cancers. Then now coming to the quality of life, which is very important. So the quality of life in the consolidation radiation arm did not deteriorate as compared to the observation arm, which deteriorated over time at about 3 months. The other thing is the adverse effects. Adverse effects, though they were there, but it was more common in elderly patients. So I would not advocate chemoradiation for elderly patients. It is safe in patients less than 60 years, and it is practice changing. So adverse effects commonly were about hepatotoxicity, radiation-induced liver disease, which was seen in 13% patients, and half of them were in elderly patients. The other was GI bleed, which was seen in about 6% of the patients, and that was fatal. So we have to be very sure about the diurnal dose to avoid toxicity.